So good afternoon, everybody. There is going to be, of necessity, a bit of overlap between what I'm going to say over the next hour and what I, along with all of you, have heard for the last 4 hours or so. But the approach is a bit different, and it's sometimes nice to hear things in another context. So we are aware of the fact that rheumatoid arthritis is inherently an aggressive disorder with attendant morbidity and mortality. As examples, there's 2 times more likelihood of having a myocardial infarction, 70% more likelihood of having a stroke, 70% more likelihood of developing an infection, up to 25-fold increased risk of a non-Hodgkin's lymphoma. Mortality can be increased up to 41%. Life expectancy can be reduced anywhere between 10 and 18 years, and osteoporosis is increased as well. Some examples are shown up here from 2 different databases. So in the orange, we have Shireen Gabriel's database showing increased mortality, and in the blue, Fred Wolf's database, again, showing increased mortality in patients who have rheumatoid arthritis. Well, we heard this morning, in fact, that the main driver for this increased mortality is indeed cardiovascular disease. There are also a number of factors that are going to influence that. One is inflammation, shown as examples of increased joint damage, elevated sedimentation rate, increase in HAC. Also, increased disability, again reflected in the HAC. And very interestingly, prednisone use as a big predictor of mortality. So we're going to look at a number of different comorbidities this afternoon. We're going to look at malignancy, we're going to look at infection, and we're going to look at cardiovascular disease. So we're going to start with malignancy. In order to understand effects that some of our treatments may have, we have to look at malignancy in the general population of rheumatoid patients. So this is something we may have seen before. So if we look at total malignancies up here at the top, there's in fact no difference between our rheumatoid patients and a general population. If we look at lymphoma, we can see an increased incidence of lymphoma in our rheumatoid patients. Also, what we're aware of is also an increased risk of lung cancer in our patients. There's a tendency toward a reduction in colorectal cancer and a reduction in breast cancer. In another database, and this is the Swedish, the ARTIS database, you'll see an increase in respiratory tract malignancies, again shown as it was on the previous slide, but here we're looking at an increase in non-melanoma skin cancers. So I think it's important, at least when we start thinking about the increased risk of the TNF inhibitors at increasing the risk of non-melanoma skin cancer, we have to remember that non-melanoma skin cancers are already increased in the general rheumatoid population before they get their TNF inhibitors. Okay. And if we want to look more specifically at lung cancer, as shown here, again, an increased risk of lung cancer in our rheumatoid patients. So now the question becomes, do the biologic DMARDs increase that risk of malignancy? And there are in fact some studies that say no. So let's look at those first. So here is from the Spanish database, and you can see that there's no increased risk of malignancy in patients treated with TNF inhibitors. And this is from the British Biologics Registry, and again, no increase. You might note, however, that this registry was not including non-melanoma skin cancers in their conclusions. Now, this is something that someone asked a question about earlier this morning, and it doesn't completely answer the question, but at least it speaks to it a bit, and that is, what about the patients who have had a prior malignancy? The question this morning dealt a little bit with how long, before you can start a TNF inhibitor after a malignancy. This doesn't speak to that, but it looks at the risk of malignancy or recurrent malignancy in patients who have had a prior malignancy who then go on a TNF inhibitor. And what you can see is that there is no increased risk of recurrent malignancy in patients who have had a prior malignancy and are now going on a TNF inhibitor. However, those small numbers, I would call your attention to the prior melanoma patients. So there were 17 TNF-treated patients who had had a prior melanoma, and there were 3 recurrences, where in DMARD-treated patients there were none. So, you can't make that much out of 3 versus none. However, I would personally be a little concerned about restarting a TNF inhibitor in somebody who had had a prior melanoma, whereas patients who had had other than melanomas, you might be safer to do so. And then the question becomes, what about over time? So we're looking at the middle graph here over 5+ years. There does not appear to be an increase in malignancy in patients getting TNF inhibitors, at least going out 5 to 6 years. Okay. And we don't want to forget our other biologic disease modifiers. So this is the data set on abatacept. And again, it's a very busy slide, but the conclusion on this slide is that with abatacept, there does not appear to be any increased risk of malignancy. Well, how about some studies looking at an increased risk of malignancy? So this is from the United States database, and what you see is that although there is no increase in overall malignancies, there is indeed an increase in cutaneous malignancies. Again, this is from Corona, demonstrating also an increased risk in cutaneous malignancies. So this was a study that we looked at a little bit earlier today. I'm not going to belabor it because it was beautifully dealt with. There were a lot of concerns when this study came out by Bongartz, published in JAMA several years ago, about the methodology, et cetera. But it did show a 3-fold increased risk of malignancy in patients who were receiving either infliximab or adalimumab. So one of the concerns when the publication came out was, why was etanercept not included? So the authors went back a year or 2 later and examined the etanercept database, different methodology, but what they did show was a trend toward increased risk of malignancy, but statistically not significant. This is some data that was presented at the ACR meeting this past winter or fall, and it looks at a database from early RA trials, and in that group of early RA patients, there was no increased risk for malignancy. Well, what about lymphoma? So we saw already this morning the kind of updated data from Becklin from Sweden, and I had the option of either showing you the original data that we quote so often or the updated data, so it was nice that we already saw the updated numbers, which show the same thing, but I thought I would just kind of show you some of the original data that we frequently quote, but maybe a lot of us haven't actually looked at. So this was looking at a 12,000-person Swedish database. It was a nested case control study with 3-to-1 matching. There were 41 cases of lymphoma, and what they did basically is they designed their own scoring system to measure mild, moderate, and severe disease. And so this is their scoring system, and what you can see is they use low disease as their reference, medium disease activity according to their self-designed measurement. There was a 5-fold increased risk of lymphoma, and the high disease activity patients is where we frequently quote that up to 25 increased risk of developing lymphoma. This is also from a Swedish database, and it actually has several different cohorts, an inpatient registry, an early RA group, and then a TNF antagonist group. And again, as you might expect, the TNF-treated patients had higher disease activity. So when you look at this database, the first thing you would say is there is an increase in hematologic malignancies compared to the general population. But it's very important whenever we look at numbers to understand that we need a proper comparator. So if RA already increases the risk of lymphoma, what we want to do is to look at a general RA population. So again, when you look at the risk against a general RA population compared to an RA population getting TNF inhibition, there is no increase.